All right, it's another Thursday, so you know what that means. There are 11 studies up here, but honestly, a lot of these are just not so much my thoughts as I just want you to know this info. Doesn't take much for me to explain either my position or what it's really about. So first up, upper limb sensory motor training and resistance training in the management of patients with type 2 diabetes. Randomized controlled trial. Basically, they found that doing anything with this population has benefit for different reasons. Resistance training, because it's a beautiful thing. Like, it is one of the closest things to a panacea in nature that we can actually do. It is protective for all-cause mortality, life quality, etc. But incorporating things like sensory motor training, because with diabetes, you do get some nerve damage with that high threshold glucose in your system for so long that does cause nerve damage. So adding in some training that, like position sense or trying to retrain your body to do things can also be a benefit, but it's not like you need to only do one without the other. These things can be synergistic, and don't complicate things. Just get out there, stay active. Honestly, the rule of if you don't use it, you lose it pretty much applies. So if you're concerned that you won't be able to do something, then just keep practicing that thing. And the odds are that it'll take a long time for you to not be able to do that, because your body says, oh, I have to be able to still move, run, whatever it is you want to do. If you actively participate into it, your body will say, all right, boss, we're going to keep the tissue, we're going to keep the motor control, we're going to keep everything we need to still be able to do that. And it's when you stop is when it's the biggest issue. But moving on, efficacy of non-surgical interventions for the management of adults with cervicogenic headache. And this one basically just reiterated a lot of what other studies showed, in that in the short term, manual therapy can be a great benefit, but it is not the long-term solution. And then there was mixed evidence at the medium and long-term results, which is basically why we came to that conclusion. So if you have a headache, understand what headache you have. That will change the approach that you need to manage that headache. So if it is cervicogenic, we can consider adjusting instrument-assisted soft tissue work, targeted hands-on soft tissue work, dry needling, depending upon what the major disability you have is. If it's just pain, if it's range of motion, or if it's something else. So even if a lot of these studies say, one is no better than the other, again, we've said it before, that doesn't mean very much, other than it lets us be flexible and selective to the patient in front of us to match to them what they're going to get the most out of that clinical experience from. So if they don't like needles and they don't have a significant range of motion deficit, don't even have to really worry about the conversation piece. If they don't care for an adjustment, but they can't really move their neck and they don't mind needles, then we can talk about dry needling. So again, if one is no better than the other in the short term, that is actually a good thing in so many ways. People see these studies and they'll just say, oh, see, it's no better, therefore we shouldn't do any of it. It's like, no, that's not what that means. But before I go on to a rant, next up, and again, this is one that I am just the messenger. I don't have many thoughts other than to tell you what this study showed and move on. Systematic hormonal contraception is associated with a greater rate of greater trochanteric pain syndrome. So basically think hip bone, so not the seat bone, but the hip bone right on the side there. It's also associated with labral tears and femoral acetabular impingement. So if you kind of get really pinchy hips, especially kind of near the groin area, it is associated with that. Now, this is not saying it is causative. If you took it, it is automatic. It's not saying that at all. It is simply saying, hey, if you happen to take birth control, hormonal contraception, there was an association with developing hip pain, labral tears, and hip pinch, like a hip pinch condition. So again, I'm just the messenger here, and I'm not going to dive any deeper than what I know about. Let's see. Cost drivers and delays in recovery following rotator cuff repair. So this is a claims database. So when you go through the finance side of medicine, you can also derive a lot of data from figuring out who pays for what was reimbursed, durations. Like, you can figure out a lot about what interventions did, how effective they were, just by taking a look at insurance claims data. So in this one, they took nearly 15,000 patients and they saw what happened when they had a rotator cuff repair. And if we go right into the results here, Of the 15,000 patients, the median surgery cost was $11,500. The average or median recovery was 153 days, so just shy of half a year. And if you had the development of a post op shoulder contracture or adhesive capsulitis, so it's thought to be extra fibrotic tissue laid down in the healing process of this post operation. So, yeah, you're healing, you have to lay down new tissue, but this tissue is extra, or not extra, it is less springy, extra stiff, and it kind of keeps everything super duper tight. That added a median of another 162 recovery days. So now you're doubling the time to recover from a rotator cuff repair if you have any of these complications, and it nearly doubled the cost. So you go from $11,500 to $23,000. Not looking good so far. Patients requiring surgery for a complication, not just the ones that we listed, had a 3.5-fold longer recovery and a 5-fold higher cost than those without. Let's see. And it talks about another situation with increased recovery time. Comorbidities extended recovery by 1 to 3 months. So if you have things like systematic issues, heart issues, diabetes, it adds 1 to 3 months in this surgery. And it's something that I also find when I work with patients. If you have comorbidities, I don't automatically think you're going to spring back like that 15-year-old. Like we all seen it. I watch it in my daughter. I watch it in my son. They can seemingly take a hit, fall, land on their knees, whatever it is. They pop right back up. And that's not to say we're not robust, but by gosh, it does take some things longer to heal. And especially if you have these comorbid conditions, it takes longer. And you got to bake that in when you're discussing what the outcome is with the patient. Comorbidities also modestly increase the cost and were associated with a 2 to 3 times higher frequency of pulmonary embolism with this surgery, which is it's a risk factor for a lot of surgeries out there. Okay. Bum, 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 bum. So let's see here. Anything else about this study other than motion surgery to restore motion? Nope, that's the same thing there. Uh, oh, one thing that they noted was there was a lack of specific clinical details, so they couldn't parse out like every patient's specific case. So again, interpret these with caution, but I think it paints a pretty good picture for us to discuss. Um, yeah, I I see this with a lot. I see this with surgeries. I see this with long-term medication use in some instances where the cost of the medication is significant and it's impacting their life, but you don't want to take the steps to consider addressing health-related issues that you can actually actively take control of, and you're just relegating yourself to this cycle of, "Oh, I'm just going to take the medication because that's all there is for me," or "I'm just going to get the surgery, so that's all there is for me." If you can set yourself up for success, irrespective of if you need the surgery or not, or if you need the medication or not, if you back it up with healthy lifestyle, it's always going to be better. You're not going to change that. So if you need a rotator cuff repair, like absolutely need it, but you're just or have been just sitting around, not doing anything, not eating well, not sleeping well, you let yourself develop chronic lifestyle associated conditions, that surgery has a much higher chance of taking 2 to 3 times longer, costing 3 to 5 times as much. And this is just with a shoulder surgery. Imagine others. Imagine spine surgery. Imagine hip surgery. Imagine total hip or shoulder replacements. This isn't a surgery good or bad discussion. This is a doesn't matter if you need it or not. Do not treat it as something lightly, like, oh, I'm just going to. No, your body's going to go through one heck of a process. Okay. You need to set yourself up for success, even if it's not for health considerations, then financial. If you don't want to spend 2 to 3 times the cost, then let's help. And that's something that I also see play out in my actual clinic or other colleagues' clinics where patients will have this discussion of, well, I am out of shape. I don't do any prehab. I am just going to go into surgery. And now we have these actual data reports of what this might actually cost them. It's like, well, it is going to be $11,000. So I can't afford your care. I can't afford, and whatever it is, let's say your premium end and you're going to ask the patient over the course of this prehab event of 3 months for an extra, I don't know, $2,000, $3,000 compared to doubling or tripling the actual cost of the total surgery from 11,000 to 20, what I say, 23 to 3,000 or 23 to $30,000. You're having an issue with 2,000. Like, I get it, it's at once and it's before and you have this impending surgery, but if you're going to spend $2,000 to then stack the deck and attempt to avoid the extra $11,500, or if you have the comorbidities and it's going to cost you even more, um, uh, $20,000, who wouldn't take that investment? Hey, spend two, save 20. But I think it's one of those things that because not too many people talk about it, people just don't know. They they don't look at that big picture of what is the entire year going to be of that surgery. They just look of everything up to that event. Like, okay, I have my deductible to meet. I've got these expenses. I've got this, which means I'm going to zero sum my book so that we get the most bang for a buck, you know, with or without our insurance, depending on their own individual situation. And then you don't look past that. So what is the physical therapy going to cost? What is potentially pain medication going to cost? What is the potentially reduced ability to perform your work if you are a manual laborer? If you have these conditions, are you anticipating potentially having to go through surgery again and extend the actual recovery time and the costs? When if you just invest a little bit more in that front end, it potentially saves you from so many more things in that back end. And that is something that clearly I'm spending so much time talking about it is so so very impactful. I can't speak up enough about it. Just consider that, okay? Just consider that for the future. All right, moving on. Synergistic effect of dry needling and instrument assisted soft tissue mobilization in a specific type of knee pain, randomized controlled trial. Let's skip to the results or methods and conclusions here. It was single blinded, 100 participants, younger age group, diagnosed with this knee pain. Participants were assigned to one of four groups. So you had roughly 25-ish people in each group. So you had 27 here in trigger point dry needling, 25 in instrument work. You had a group that had combined trigger point dry needling and instrument work and a control group, so they didn't receive anything. The intervention groups received 2 treatment sessions per week for 4 consecutive weeks, so a total of 8 treatments, in addition to a standardized exercise program. And then they used these different surveys essentially to figure out if it was effective. So what were the results? Combining trigger point dry needling and instrument assisted work demonstrated superior improvements in both outcomes. Pressure pain threshold increased by 80% and other scores improved by 40% in the combined group. By comparison, if you did try trigger point dry needling alone, it showed a 53% increase in pressure point threshold, and then the instrument assisted group showed a 54%. So each one did well respectively. Combine them, they seem to do better. But again, going back to my prior point, it really comes down to the patient in front of you and what is best for them. So if you have a patient that absolutely will not do needles, don't bother trying to combine them to get that extra 20 some odd percent benefit to that patient. Just leave it at the instrument because you're still going to get some sort of benefit. Same thing, vice versa. If they only want needles because for some reason that's their jive, like just treat the patient in front of you with this in mind as a factor, not as a handcuff. All right. We're almost done. I mean, it looks like we're only halfway, but truly we're almost done. Knee pain is associated with complex gait deviations, and they use an AI to kind of watch somebody's walking. Do I really need to state it? If you have knee pain, it's going to change how you walk. This study just said we used AI to track it. Weird, right? We kind of see something similar. Lower limb biomechanical differences in runners with long duration and short duration knee pain. Same thing. Small group of runners compared to the control group, the long duration knee pain group demonstrated significantly greater peak knee external rotation, knee abduction. They're just listing out the motions that these people had a variation on. So your body's going to adapt depending on what it's going through. So if it's going through short-term pain, depending on the severity, maybe little, maybe a lot of adaptation or different movement patterns. If you have chronic knee pain, maybe it's not as obvious. Maybe it is. Who knows? Basically, what we say is treat the person in front of you. If you have pain, you're probably going to walk or run different. It makes sense. And it's just something to have a discussion with the patient in front of you to see how much we want to use that as an outcome assessment as far as, yeah, your running economy is going to improve or yada, yada, yada. Personally, for me, running is something that is difficult, even with the technology that I have, to be completely objective with. So with runners, we'll do as much as we can in sterile environments when it comes to assessing their ankle strength and range of motion, knee strength, range of motion, and hip strength and range of motion, and build an actual profile to go from there. But when it comes to the actual act of running, I usually go about it as I will try to change their technique, not directly. I'll try to change it indirectly. So if there's something major that the patient is complaining of because they feel like their running is off, I won't immediately just jump to their running pattern and say, all right, you know, you should do this angle forward. I won't change the posture, the dynamics of it as a first line resort. I will typically try and go and attack the underlying potential factors that is leading them to developing that gait in the first place and letting the body then restructure and repattern around this restored motion or reduced pain. And typically it resolves itself. The only instances that I really go towards running when it comes to affecting their symptoms, because running can be so subjective, because it's sometimes a feel as much as it is a witness thing outside of a significant biomechanics lab, really comes down to periodizing it differently. So acting more as a, hey, because you have this sort of pain and we don't have a bone stress injury, maybe you're just doing too fast for that distance, or maybe you're doing too much distance. So we'll play with their running total and running speed first before we'll really try and get into, well, you must shorten your stride, or you must, try and think about doing this while you run. That's not nearly as effective, I found, because it's not as easily controllable. What is the underlying factors that lead to their natural gait pattern. Having a couple of in my pocket modifiable things within a run to attempt without changing their actual structure, and then taking a look at running as I do with strength training, in the sense that the equation deals with volume, time, load, all of these things, and we can modify those bigger picture things to then help the patient in front of us before we have to fiddle with technique too much. Um, like about the only exception I can think of is, you know, when it comes to knee torque, and if we find that that's a significant driver of pain, then we might say, all right, reduce total mileage by 10%, and then let's try shortening your stride a little bit. So try and, rather than pushing for longer major strides, keep it nice and easy. So your pace might increase, but your stride will decrease. I don't know. I'm starting to ramble, and hopefully it made sense. I'll try and TLDR it. The TL the TLDR is essentially running's complicated. There's only a few things that you can really do that may be effective for the knee from a running pattern standpoint when you tell a patient to do something while they run. Ergo, longer strides or shorter strides. A lot of the times it's going to err on the side of shorter strides. Typically, the most effective things to do for that patient is from a training template standpoint, affect their running volume, running pace, um, and running distance so that we're modifying the total load of a run and then taking care of the underlying factors and letting the body restructure around a more optimal movement pattern for that individual. I'm gonna I'm probably gonna confuse everybody if I keep talking because it makes sense in my brain, but it's not making sense the way that I'm trying to say it right now. All right, we've got 4 studies left. They're a lot shorter, I promise. Sleep quality on the effectiveness of repositioning therapy for patients with BPPV, basically a certain type of vertigo. It makes you feel dizzy. Repositioning maneuvers affect or is thought to affect these inner ear not ossicles, otoliths. They're like ear crystals, and if they dislodge, it creates a cattywampus effect where your brain and ear aren't communicating well and it makes you dizzy. So, one thing you can do for them is go through these different head positioning maneuvers to guide that otolith back in its proper position. And shocker, shocker, in this one, if you have reduced sleep quality, you're probably going to have reduced effectiveness of repositioning maneuvers. So basically, in the conclusion, poor sleep quality is associated with higher lithiasis prevalence and treatment resistance, and you have residual symptoms which can affect your social functioning. So if you want to get better, especially with BPPV, get some sleep. Randomized controlled trial comparing physical therapy with low load BFR, blood flow restriction therapy. This is something that we do have and we do utilize at the office. I'm going to read this first and then I'm going to point something out and I'm going to ask you guys what you think about it. So, first up, they wanted to see if BFR is superior to standard physical therapy when treating lateral epicondylitis, so elbow pain. Randomized controlled trial comparing the two program over 6 weekly visits. So he had a patient with BFR doing weekly visits for 6 weeks and standard physical therapy with a weekly visit over 6 weeks. They came to the conclusion that this real world trial suggests the addition of once weekly BFR physical therapy is no better than simply performing a standard once weekly heavy load standard physical therapy protocol. If you're watching my screen and it's big enough, you might have seen it already. I'll read the results and then I'll go back to the methods and we'll see why I have an issue with this one. 41 patients were enrolled. They were analyzed using different things. They were subdivided between the groups. Blood flow restricted physical therapy showed non-statistically significant improvement at 12 months compared to standard physical therapy. Secondary outcomes also showed non-statistical significant differences at 12 months, favoring standard physical therapy, between group difference, pain-free grip strength favoring standard physical therapy, and maximum grip strength also favoring standard physical therapy at the completion of therapy. So let's go back to methods. So I said it before, that randomized controlled trial comparing the two. It was over 6 weekly visits. The primary outcome was the change in the patient's elbow evaluation score at 12 months. I'm kind of confused on this one because if you do something for once a week for 6 weeks, then you wait a year and your results are that neither one really did better and it's slightly favored standard physical therapy. Therefore, BFR is not that useful in this condition. I don't understand the setup. You did a month and a half of these interventions, and then you asked people after a year, like, what? You came to the conclusion without listing that you 6 times. So let's read this conclusion as is, and then let's read it. This real-world trial suggests the addition of once-weekly BFR physical therapy is no better than simply performing a standard once-weekly heavy-load standard physical therapy protocol. Or this real-world trial suggests that the addition of once-weekly BFR for 6 weeks is no better than performing standard physical therapy once weekly for 6 weeks. The conclusion that they have is just so misleading to the actual study setup. And I don't think I don't know if this condition is ideal for blood flow therapy from a population standpoint. So BFR can be controversial because there are some studies that show, like this, better ones, that BFR is no better, because if you actually get the patient to push closer to failure, they're going to adapt, therefore they're going to get better. And doing BFR right is very uncomfortable, and it is difficult to get the patient to necessarily push as hard for the adaptation. It's the point of BFR. You're able to change the stress going through the actual limb you're occluding, so that rather than high loads of mechanical stress, which the body may not be ready for, you can induce additional chemical and physiological stress to get the adaptations you're looking for. It's also why it's very prevalent in post-surgical, post-op conditions, because you can physiologically stress the tissue without mechanically overloading it. You can still get the patient to essentially spring back stronger, and they feel like they're able to accomplish more, because if you have, let's say, a total surgery or total joint replacement on like the right shoulder versus the left, um, your left one may be at your normal strength. Let's say you're used to bicep curling, I don't know, 45 pounds. You can't bicep curl 45 pounds yet on this shoulder, and probably for quite some time, just given the nature of the surgery. That is going to impact the patient potentially psychologically, socially, if the gym was their thing, a lot. But if you include BFR, where they are able to utilize that joint at a much lower load, where they can still actually go into the environment that makes them happy, that actually makes them push and makes them more compliant, even if BFR compared to really heavy loads, they don't really pan out as one is better than the other, to the point where, why go through the discomfort of BFR? Like a lot of our other interventions, it is patient selective. So this is why I don't think these mass population-based studies of BFR are necessarily going to demonstrate effectiveness, because to do it effectively, it's not going to be comfortable. I've had to put tourniquets on before. It's not going to be comfortable. However, if the patient can bear with that level of discomfort, because the benefit is them able to mentally get into the activities they enjoy and the social interactions they love, BFR is going to probably, in their scenario, be better for them than, you know, telling them to wait to push heavy on this arm, do some cardio in the background to stay healthy overall, which is still great. But if they're used to dumbbell curling and now you're telling them to use like the itty bittiest band and they're just sitting here, even if from a population standpoint, the person doing the light band work versus the patient doing the BFR work is going to be averaging the same. Those are averages. If you zoom it in and you got the guy that is just going to fall off the bandwagon, do the BFR. So I don't like this study. BFR is something that, like anything else, I'm agnostic on because I don't care what necessarily gets the patients better ethically, but we can't throw the baby out with the bathwater. So I think these studies are, or this one is poorly designed, and BFR is going to be something that is condition specific or treatment specific, i.e., like post op, and much more patient specific given the conditions of that patient and when and how to use it. Last two studies. Comparative effectiveness of laser, PRP, splinting, and shockwave versus corticosteroids in that same condition, lateral elbow pain. Almost like I just said with this segue here, conservative and injection-based modalities provided meaningful short-term improvements in patients with that condition, that lateral elbow pain, while corticosteroid injections produce the most rapid pain-relieving effect because that's what they're supposed to do. Non-invasive interventions such as low-level light therapy or laser therapy, splinting, shockwave achieved comparable functional benefits without the risk of that invasive therapy. Although PRP improved pain and functional scores, it was so far limited in effect on hand grip strength, which suggests that it may be considered as a supportive option in selected patients. Just to go and show again, you can select and be patient specific with the intervention that you're choosing to use depending upon what that person is most likely to get better from. And not because of the actual physiology of the condition, but because of the actual clinical interaction of that patient. For example, shockwave. A lot of the times, if you do it right, oh boy, you are going to feel it. Some patients need to feel it in order to presume they're getting better. So you can patient select those patients into that treatment category. Low level laser therapy, you don't feel it at all. So if you have a patient that is pain averse or actually prefers to just relax for a little bit longer because that light's going to take time to penetrate the tissue, then you can select those patients into low-level laser therapy. The patients that don't care necessarily about the injection side of things, they don't mind the needle, let them get the injection because it's going to have the most pain relieving effect immediately. Again, patients select the treatment. There are differences in the actual mechanisms of these treatments that may supersede what I'm saying, but in a general discussion, all I'm saying is you can subdivide these patients based on their likely benefit of the therapy itself, based on who they are, not what the condition is. There will be certain times, depending upon what led them into a certain condition, that may predispose you to selecting a specific modality because of its physiological mechanisms or theories of improvement. But if you either don't know or it's not going to matter for that patient which one you do, then pick the best one for them. Okay. So TLDR, all of these work. You can patient select and subdivide the best patient for the treatment because they seem to all work. And there's only going to be certain times when the actual mechanisms of these interventions truly matter and may warrant a discussion with the patient away from their favored therapy. So again, exceptions, not the norm. Last but not least, if you have plantar fasciitis or fasciopathy or whatever new word they're using to describe it, we may be able to see it with ultrasound now, so we can add some potential clinical certainty with a relatively inexpensive imaging modality. And this is something, again, not like out in the practice models yet where I can guarantee like all imaging centers are going to be able to do this, but this is a prospective, hey, in this study, we did note key signs of plantar fascia thickness and fat pad measurements that corresponded with patients that had plantar fasciopathy, which means we're looking like we could be able to diagnose this with ultrasound. They're going to add more data to it just to make sure, but if that is the case, awesome. The more things that we can utilize to diagnose patients, the to give them cost-effective, evidence-based imaging is going to be great. So rather than having to either go to high cost things like multi-level MRIs with contrast versus like it's just a great prospective thing to see. So I'm going to keep my eye on this to see if and or when it's going to come across into the guidelines. But maybe in the future, if you have plantar fasciitis and we're working together, or I suspect you have plantar fasciitis, and you don't want to just rely on symptoms to say yes or no, you have it or not, we might be able to consider an ultrasound in the near future. So I went on way longer than I intended. Thanks for hearing me ramble and rant. And until next week, thank you.